Hello, I'm Peter Chen. On behalf of CME Outfitters, I'd like to welcome you and thank you for joining us for today's educational activity entitled The Growing Body or Antibody of Evidence for the Treatment of Mild to Moderate COVID-19. Today's program is supported by an educational grant from Lilly. For further information concerning Lilly grant funding, visit www.lillygrantoffice.com. So today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. We're offering CME credit today, so to get your CME or CE activity, you have to just enter your AVIM MOC, or AVIM number and date of birth, and they will make sure that they get you the MOC points. They also offer MIPS improvement activity. So to get that, you have to complete the survey within 3 months. Provide examples of the changes you made to your practice, and CMEO will send you confirmation of your participation, which can be submitted to CMS. One of the new things they're offering are these digital badges, and you can get this digital badge, as you see on the screen, for COVID-19 monoclonal antibody treatment training. Once you complete the program, you just have to do the post-test, claim your credit, and you'll get this digital badge that you can share across social media. You can embed in your email signatures, your resume, and web pages. I also want to encourage everyone to join us today on our live Twitter conversation. It's at CME Outfitters. We'll be monitoring the Twitter feed and respond to your tweets as they come in. We're also using an enhanced platform today. You can save your slides, you can take notes on the slides, you can answer polling questions, and you can send us your questions. So continue to send us questions. We'll be answering it throughout the presentation, and at the end, we'll take time to also answer as many questions as we can. So as I mentioned, I'm Peter Chen. I'm a professor of medicine and biomedical sciences and the director of Division of Pulmonary Critical Care Medicine at Cedars-Sinai Medical Center in Los Angeles, California. I have a great panel with me today. I have Dr. Gregory Hoon and Margot Savoy. Let me introduce you to both of them. So first is Dr. Gregory Hoon. He is the COVID-19 vaccine coordinator and senior director of HIV services at Cook County Health and an associate professor in the Department of Internal Medicine and the Division of Infectious Disease at Rush University Medical Center in Chicago, Illinois. Welcome, Greg.
All right. Thank you, Peter. Happy to be here.
I'd also like to welcome Dr. Margot Savoy. Margot is chair and associate professor in the Department of Family and Community Medicine at the Lewis Katz School of Medicine at Temple University in Philadelphia, Pennsylvania. Welcome, Margot.
Hi, everybody. Thanks for joining us today.
All right, great. So we have 3 learning objectives that we want to go through today. And we're going to start with this first one, which is on screening assessment for early and accurate diagnosis of mild to moderate COVID-19 to guide treatment decision-making in high-risk patient groups. And to kick it off, we're going to have a patient case. Margot, do you mind starting us off with this patient?
Sure, happy to. So let's talk about Stephen. So Stephen is a 34-year-old man who comes in complaining of muscle aches and fevers. He's had a runny nose, some nausea and diarrhea for the past 4 days. He does tell us that he's not been around anybody with upper respiratory tract infection symptoms, and he hasn't really been anywhere except for church and to the grocery store. He does have a BMI of 36. He has a hemoglobin A1C that was 6.7 a couple months ago when you checked it in the office, and he takes metformin daily. Your temperature for him when you had him in the office was 100.7. He had a blood pressure of 130/85, and his heart rate was 90. Fortunately, his pulse ox was 98%. So I guess the question would be, what would you guys want to do as your next step for Stephen? So given the way he's showing up in the office, what would you want to do as your next step? So would you A, recommend getting plenty of rest and fluids? B, prescribe azithromycin, rest and fluids? C, test him for SARS-CoV-2 virus? D, test him for SARS-CoV-2 virus and order a chest x-ray? Or D, I'm not really sure. And it's okay if the answer is I'm not sure. So why don't you give us your answer on the poll? So we've got a lot of different options going on here. So most of you are saying that you would like to test for the SARS virus. So for the COVID-19 virus, some of you are saying that you would test, but also order a chest x-ray. And a few of you are just not so sure altogether. So what we would recommend, just sort of, we talked about it beforehand, is that we would definitely test for the SARS-CoV-2 virus. We're not so sure about the chest x-ray one, so we didn't pick that one yet. But I like where you guys are headed. So I think you're going to get something out of today's talk. let's think about his symptoms a little bit more. So given his presentation, and let's pretend that we know that his test comes back positive. So we get the test, it comes back, it's positive. How would you characterize his symptoms? So just based on the way he was presenting to us in the office, would you consider his case to be a mild one, a moderate one, a severe one, or you're not really sure? So what do you think? How severe are his symptoms? So most of you are thinking that his symptoms are pretty mild. There's a few of you that consider them moderate, and a few people that are just not really sure. So I think we're gonna get into this a little bit more and help some of you that were a little bit on the fence have a better understanding of how you would classify it in just a bit.
Right. So, there's a lot of different groups that have decided how to gradate the severity of illness. Right here, we have the NIH guidelines. Margot, do you mind going through the NIH designation of what a mild, moderate, and severe disease is?
Sure, happy to. So you guys have already figured out that COVID-19 is certainly showing up as a spectrum of illness from mild to severe disease. Those with mild disease often can be managed in your outpatient setting or sometimes even from home with you sort of managing them over the phone or using telemedicine. If they don't have pneumonia or hypoxemia, but they can still have some of the other symptoms. So for example, they could still have fevers and chills, cough, even some of the GI symptoms, but they're not having any pneumonia and no hypoxemia, then we're considering them to be mild. On the other end of the spectrum, you've got folks who have severe disease. Severe disease folks are going to have more dyspnea and shortness of breath. They're going to have hypoxemia. Often, if you're doing imaging, you're going to find that they have infiltrates on their imaging. In fact, more than half of the people will have some kind of an infiltrate, either on a chest X-ray or on a CAT scan if you're doing the severe cases. These folks are important to figure out because they often will progress quickly and need to be hospitalized if they aren't already at the time that you're diagnosing them. And many of them will end up needing ICU level care or just advanced ventilatory support at some point during their course of their illness. And so it's important to be able to distinguish between one and the other.
Yes, I totally agree with you. And, one of the things that we have to remember is, everyone starts at a very mild level, but we don't know who's going to become that severe disease. And the people who do, by the time they get there, it's a little bit too late. So we want to see if we can identify them early and prevent them from going into that severe disease. But what we do know is that there's certain risk factors associated in those that will get severe disease. So Margot, do you mind going through some of those risk factors?
Happy to. So as you can see on the screen, there's a wide range of risk factors that should raise your concern for a patient that you're caring for, that they have a higher risk of progressing on to having severe disease, older age, being pregnant, or having chronic medical conditions. So for me, the chronic medical conditions really stands out because there's a wide range of them that could really get people in trouble. So things like diabetes, cardiovascular disease, underlying kidney disease or lung disease, even neurologic disease or hematologic disease, just to name a few of them. We also need to be mindful that there can be folks who don't necessarily have diseases that you've identified, but they live in spaces or places where they have systematic health and social inequities. And that also can be associated with higher rates of infection with COVID, but also with more severe disease and increased risk of progression and death. So it's not even just the diagnoses that people may carry, but it may also be sort of where they're living and the circumstances that they're working in that might create a higher risk for them.
Great. So, over the last year plus, year and a half, we've really made a lot of advances and we understand the disease a lot better and how to treat the patients that have COVID-19. And so, Greg, you're an ID specialist and you've been working frontline, you've been part of a lot of the trials. Could you go through the guidelines here that we have from the NIH on the treatment of COVID-19?
Yeah, thanks, Peter. These are evolving dynamic guidelines. They're available online. And, together with CDC guidelines, NIH has a comprehensive portfolio of how to approach the patient on an outpatient basis. So when you take a look at supportive care, when we talked about Stephen, some of the options were, hey, does he need rest? Does he need fluids? Certainly, that's a supportive care, proper nutrition. And actually, through CDC guidelines, he's going to be isolated. He's going to be under quarantine. And if it's mild disease, then that's a 10-day period where he will likely then have virologic decay and then no longer be transmissible or contagious. He should engage in telehealth. We've all been now immersed in telehealth. I find it very valuable, certainly with my connection to my patients, but certainly for those that are managed on an outpatient basis for COVID-19, plug them into telehealth, let them know who they can contact, healthcare provider, if they progress, if they need to seek an in-person evaluation, the mechanisms for that. Importantly, patients with dyspnea, we provide actually pulse oxes for our patients. If they're going to be managed on an outpatient basis, we can provide a pulse ox. They should be measuring actually their pulse ox. Very easy to do. And if those oxygen saturations dip in the 94% or below range, and patients may progress then with more pulmonary symptoms, even acute symptoms of chest pain, tightness, the dizziness, changes in mental status, that's when they're going to be really perhaps more into the second week, progressing to that severe manifestation of COVID-19. They should absolutely be referred for inpatient evaluation and closely monitored then, particularly with worsening respiratory symptoms. But overall, when we take a look at the management plan, we need to identify who's going to be at risk earlier. As Dr. Savoy, Dr. Chen pointed out, who's going to be at risk. We want to capture them early. We want to know how's their vital signs looking? If they need to come in for an in-person evaluation, are they at risk for progressing? This is where you're going to get a chest x-ray, right? But before we do that, we really want to establish who's at risk to prevent that type of complication that can happen, usually pivots within the second week of disease. So let's move on to take a look at then our options, current therapeutic options, and most of these actually reside in the inpatient domain. Steroids, dexamethasone, antivirals, remdesivir, convalescent plasma, cytokine inhibitors, and other immune modulators. But I bolded here the monoclonal antibodies, and this is really going to be, and this is our sentinel outpatient therapy. And if we take a look at the right-hand side, the target populations, prevention, certainly we're not there yet with the emergency use authorization. So I'm going to focus in on those that are the appropriate candidates for vaccination. Certainly those are at high risk for progression. People that may not respond to a vaccine, the immunocompromised, those certainly receiving B-cell depleting therapies, those that may be allergic to vaccines, and absolutely those in congregate settings. These monoclonal antibodies have been examined, evaluated thoroughly in those nursing home settings where they can be most beneficial.
I totally agree with you, Greg. That was fantastic. And, one of the things that we also have to remember is that even though a lot of our population is vaccinated now, there are going to be breakthroughs as well as people that just don't want to get vaccinated. So we still have to keep in mind, how do we treat the patients that do get infected? There are a few questions coming in. I'm going to take a little bit of a pause here and answer some of them before we continue to move on. So the first one that I have is someone was asking about the accuracy of the pulse ox, especially patients of color. I think that's a great question. One of the things as a pulmonologist that I tell a lot of people, and I tell everyone to get a pulse oximeter when they get infected or even prior to infected, just in case. The ones that you get at home are not as accurate as the ones that we have in the hospital, and they tend to be a little bit off. But what I really tell people to monitor on those pulse ox is get a baseline and watch what the trend is, because you can follow the trends very nicely with those. And I've seen people that when they give me an initial pulse ox, they'll say it's in the low 90s, and then they'll go to the ED and it'll be in the high 90s. And it's because those things, again, are not accurate, but you can trend them out because you can see changes. One question to you, Greg.
Before you move on from that one, I think it's important to really point out to people that they may be inaccurate, but they're not inaccurate like magnitudes of 20s and 30s. So if they're getting a pulse ox and it's coming back in the 70s, that's not because you happen to be a darker skinned person trying to use a pulse ox. You need to investigate that further. And so sometimes people are discounting the numbers that they're getting because they're hearing that it might not be accurate. We're not talking about those huge numbers and swings. We're talking about 5, 10 points maybe, but not 10 or 20 points. So if you're really getting numbers back that are in the 70s, you need to trust that number, that at least it's low, even if it's not exactly the number that's on the pulse ox, and get that person further evaluated.
Great point, Margot. Excellent point. A couple more questions. I'm going to just kind of pause it to answer here. I'm going to ask Greg first. And one of the questions is, do the guidelines adjust for medical comorbidities or smoking?
So when the guidelines actually then put in the category of chronic pulmonary diseases, I guess that you could look at where we find our patients with COPD, asthma, and if the smoking contributes to that, then that's a chronic medical condition within the pulmonary category that would put them as qualified under the indication for the EUA for monoclonal antibodies. It does not specifically say smoking, however. You really have to have that consequential type of pulmonary condition to then be eligible.
Right. And I think also thinking outside of the monoclonal antibodies, those other treatments such as remdesivir and dexamethasone, those are comorbidity independent. It's really based off of if you have a low saturation and hospitalized, as far as I understand.
Right.
So then one final question we're going to answer before we continue to move on. And this is to you, Margot. So the characterizations of disease severity, are they dependent on age, gender, or race?
But not necessarily. I mean, we do know that if you have some of those other risk factors, like for example, you do live in an underserved area or that you have an older age, that you're going to have a higher risk. But the way that you're going to characterize the severity of the disease is really going to go by the presentation of the patient at the time. So I could be a young person and still come in with pneumonia and hypoxemia and still be considered a severe disease case, even though I'm a young person. And so really you want to focus in on the symptoms that the person is having and the signs that you're able to find on your exam as opposed to that. But what you're looking for is whether or not, if I saw a person and they seem like they were mild, but they've got multiple other risk factors, maybe I don't let them go a week before I do a check-in and follow up on them. Maybe I'm going to check up on them in a day or two and make sure that they're doing okay, because you don't want them to turn a corner and you miss the part where you might have been able to get them advanced to a higher level of care and reduce their overall risk of having problems.
That sounds great. Okay, so I think we're going to move on. So we're really going to start diving into the monoclonal antibodies now. And Greg has already kind of touched on a little bit with the overall treatment algorithm. But Greg, can you talk a little bit about the two combinations of monoclonal antibodies that we have available right now through the emergency use authorization from the FDA?
Sure, and we're going to get more details about what actually is a monoclonal antibody, but right now, two combinations. You know, a lot of people refer to them, are these the cocktails? Well, both of them are actually a dual monoclonal antibody combination. The first one is bamlanivimab with etesevimab. And then the second one is casirivimab and devimab. And these were authorized under EUA. It permits for these monoclonal antibodies to be used, again, as Dr. Savoy pointed out, those that have the underlying medical conditions, ambulatory therapy, mild to moderate, with a caveat for those that may be hospitalized. I'll get that into the one of the further slides. But those that are 12 years of age and older that are diagnosed with SARS-CoV-2, viral testing, antigen testing, that are certainly at that high risk for progressing to severe disease and or hospitalization. So these are the two combinations that are now under EUA in the United States. And importantly, when I mentioned who should be identified for this type of therapy, you should start this therapy as soon as possible, really, with those that are at risk for severe progression, really upon diagnosis, or at least consider it. And so we really have a window. It's 10 days or less, much better if it started earlier, because again, as I mentioned, after day 10, really that virologic decay can be at the point where there's really no longer detectable virus. When we take a look at the variants now that are circulating here in the United States, and Dr. Savoy will point this out again in finer granular detail, those, particularly those that contain the mutation E484K or the EEK mutation, that can reduce the virus's susceptibility to bamlanivimab and to a lesser extent to casirivimab and etesevimab. This is in vitro studies. These need to be considered as far as which monoclonal antibody you will deploy for your patient. There is now emerging evidence that there may be limited activity for some of these monoclonal antibodies in the setting of this mutation. Now, you should also be considered in persons with mild to moderate COVID that are actually hospitalized, but they're hospitalized maybe for a different reason outside of just their COVID-19. And so if they're hospitalized not for progression of COVID-19, but they are actually PCR positive, antigen positive for COVID, so they have established diagnosis, within that 10-day period, they should be considered for as a candidate for the monoclonal antibodies.
That's great. So, you know, we're going to go into a lot more detail in the coming sections. So everyone be patient with us. We're just trying to set up the discussion right now. We will go into all the details of how you're going to give these antibodies, who's selected for it. But one of the key points I think we're all trying to point out right now is you got to give it early, because we don't know who's going to become that severe disease. So if they fit within the criteria, and in particular, if they just have a risk factor, they're probably going to fit within the criteria. You should consider to give it to them the monoclonal antibody. Now, there are some limitations to the use. Greg, do you mind going through some of those?
Sure. As I mentioned, you know, those that are hospitalized because of COVID-19, they're moving in more to a sort of a hyper-inflammatory phase. those patients actually should not be administered monoclonal antibody. We have not seen benefit within that population. And really that dovetails onto those that would require oxygen therapy. Those that would require oxygen therapy usually should be, because of COVID-19 in a hospitalized setting. And again, when I mention those people that would be hospitalized not due to COVID-19, let's say some persons actually have COVID-19, let's say they have underlying pulmonary conditions that would require baseline oxygen therapy, those that are just on O2 at home. If you have an increasing baseline requirement, then that would likely be due to COVID-19. They would not as well be eligible because that's really a progression beyond the point where the monoclonal antibody may be of benefit. And then again, if they're really progressing, requiring high flow oxygen, mechanical ventilation, those candidates should not be considered. They should be considered on the other left-hand side for those therapies, as we've discussed, steroid therapy, remdesivir, and perhaps other immune modulators.
Right. So this once again reiterates, we got to give it early. If you wait too long, if they say, well, I feel fine right now, and I'll just wait a little bit, they can miss their window of opportunity. The analogy I often give people are, if you have someone that has pneumonia, you wait to give them antibiotics. Because if you wait, sometimes they can develop full-blown sepsis, and by then the antibiotics aren't going to help you. So similarly with viral pneumonitis, pneumonia, you should really treat the virus as soon as you can, try to suppress that viral load so it doesn't cause its damage. Now we have a couple of other questions. So Greg, I'm going to ask you this one. Is only combo therapy appropriate? Is there no efficacy of the monotherapy? And what is the mechanism of that? We're going to go into a little bit more detail later on, but I just kind of let you touch on some of the highlights right now.
Sure. The first monoclonal that was authorized under EUA was the bamlanivimab. Sorry, I usually nail that. Bamlanivimab. Sorry. And as we've progressed actually through the pandemic here in the United States, we have an introduction of variants. These first were introduced by the B117 from the UK. There was B1351 from South Africa. We have the P1 variant now circulating here in the US, first from Brazil. So as the virus actually has accumulated some mutations in the receptor binding domain, the bamlanivimab, which was first isolated from one of the first patients actually in the US back in January of 2020, that monoclonal antibody derived from that person's blood is no longer active against these circulating variants. So now it's all combination therapy within those two cocktails or combinations that are now under EUA.
Right. And another question that came up is any barriers with access to the monoclonal antibody for mild treatment for SARS-CoV-2, and will it be covered for patients? We're actually going to go through a lot more of these details later on. Essentially, the antibodies are free. The government has paid for it. We, as taxpayers, have paid for it. Okay. So let's move on to the next learning objective. The second learning objective, we're going to talk about the efficacy and safety data for monoclonal antibodies. So with this, we're also going to have another patient case. Margot, do you mind starting us off again?
Sure. So let's talk about Gwen. So she's a 31-year-old female who presents with a sore throat, anosmia, and fever for the past 3 days. She received her first vaccine dose 6 days ago, and she's wondered if she's having a delayed reaction to the vaccine because she's just not feeling well. She reports that for the most part, she continues to wear a mask, and she hasn't really been going out a lot. But since she's been vaccinated, she's felt a lot more comfortable resuming some of her social activities, like having dinner with her friends. So the question would be, what do we really think is going on with Gwen, right? So what would be your next step? So would you first just assure her that it's really unlikely that she would have a reaction to the vaccine at this particular point in time? Would you B, recommend that she rest and get plenty of fluids and just really reemphasize the fact that she's going to need to get that second dose of her vaccine? Would you C, do a test for SARS-CoV-2 virus? Would you D, do a test for SARS-CoV-2, but also recommend the rest in fluids? Or E, you're not really sure? And remember, it's okay to be not sure. Go ahead and take a vote. Tell us what you think. So we're a little bit over the map. So most of you are saying to do a test for the SARS-CoV-2 and make sure she gets some rest and fluids. Some of you are thinking that you recommend the rest and fluids and just really remind her about the vaccine. and then a little bit less of you thinking about just doing the test. So when we talked about this as a faculty, we kind of thought that, D was probably the best answer, that you definitely want her to get the rest and fluids because obviously she's having symptoms and you don't want her to become dehydrated or have an issue. But you definitely need to test her for SARS-CoV-2. So it is possible for you to develop an infection with COVID-19 after you've gotten the first dose of your vaccine. You're not fully protected after one dose of the vaccine in a 2-dose series. It takes 2 weeks after that second dose before you actually have full protection. I know in our hospital, we've been seeing a fair number of people who got really excited about that first dose and then went out and celebrated and ended up in the hospital with infections. And so I think it's really important for us to talk about it with our patients and make sure that they're aware of the fact that that first dose of the vaccine doesn't necessarily protect you against getting infected, 100%. So we definitely want to test her and make sure that she doesn't have an infection, and then also make sure she's getting the rest in the fluid so that she can recover.
Yes, absolutely. I think with the vaccinations, especially the Moderna and Pfizer, it's a 2-step vaccination. We know that with these vaccinations, when you look at antibody levels, neutralizing antibody levels, you don't get your full protection until you get that second shot. And particularly with variants, the higher the antibody level, the better it is against that. I think there's a lot of questions about vaccinations and the use of monoclonal antibodies. And in the case that we highlighted here, it's someone that actually got the vaccination, and many people wonder if they still qualify for the monoclonal antibody. And yes, indeed, as we demonstrated here, with even if you had 1 shot or if you had 2 shots and you do develop symptoms from COVID, you still do it or gotten the monoclonal antibody. What should we do about vaccinations if they haven't been vaccinated yet?
Sure. So the magic number to keep in mind is 90 days. So 90 days is the number you want to keep in the back of your head because that's usually the right answer for a lot of these questions. But for those who have been infected with COVID-19, what the NIH is recommending is that you defer the vaccination for 90 days. So it's not necessarily that like something horrible is going to happen if they accidentally get it on day 89 or anything like that. But the idea is that most people are highly unlikely to get infected within that first 90 days after they've been infected. And so it makes sense to sort of defer the vaccine until it's going to be more productive for them. So that if you wait the 90 days and then give them the vaccine, you sort of extend their time of protection a little bit further than if you were to jump ahead and give the vaccine a little bit earlier. And then you lose some of the days when you might have been protected within that window where you might have already been low risk anyway. Now that we do have these antibody therapies that are sort of widely available, we have to consider what do we do if a patient ended up getting treated with one of the monoclonal antibodies in between or like during the time that they're getting their actual vaccine. So for example, in the patient that we just talked about, what if she did get treated with monoclonal antibodies? When does she get that second dose of the vaccine, or does she get it at all? The answer is still 90 days. So that if you get treated with antibody therapy, you're going to wait till 90 days after the antibody therapy has occurred before you give that second dose of the vaccine. But you don't need to restart this series. So you're not going to go back to step 1 and sort of give both doses again. You're just going to pick up with the second dose, but you want to wait 90 days until after the antibody treatment is over before you give the second dose.
Great. And, one question just popped in about do current labs test for RNA from the vaccine? The tests don't test for RNA. What they're testing for is antigen, these antibodies. If you're testing for IgM or IgG, it's testing for the antibodies against the protein. Now, you have to remember the RNA, the vaccines are introducing RNA for the spike protein specifically. And so we generate high levels of neutralizing antibodies towards the spike protein. Now, it depends from your hospital where you're getting tested at. At our facility, our IgG only tests for the nucleopeptide. And so therefore, if you did a IgG test in someone that was vaccinated or got the monoclonal antibody, it would not detect that and it would not register. And so that's a huge mistake that many people do, is that they get vaccinated and they send them for an IgG test to make sure, and it comes back as 0, and they all freak out that they didn't get vaccinated. So that's something to keep in mind.
Yeah, one other thing to keep in mind, though, it also, it's not really recommended that you actually do some sort of, confirmatory antibody testing following vaccination. What we know, the numbers hold up from the clinical trials, the 94-95% for the mRNA vaccines for efficacy. They hold up in the real world setting. MMWR CDC published 2 weeks ago, 94% effectiveness for the mRNA vaccines with 2 doses and 64% with the 1 dose. So it is important. This is a 1-dose story here. So there can be breakthrough infections, and that's why it's important to focus on.
Right, exactly. Thank you for clarifying that, Greg. And there's been a lot of real world data coming out about the efficacy, effectiveness of these vaccinations, such as a big one from Israel also. So, okay, so then why don't we talk a little bit about the variants? These are really on the forefront of our minds right now. And how do these variants really play into these therapies that we have, particularly the monoclonal antibodies? Margot, do you mind going over that?
I do think it's important to take a moment to appreciate that one of the challenges that we're going to continue to face as we go forward is trying to use neutralizing antibodies for COVID-19 when there's variants sort of coming out of the woodworks. Now, keep in mind that this is not actually a surprise, of course, right? I mean, viruses get hip to our treatment games and sort of modify themselves so that they can be more effective carriers and transmitters of themselves. So if they didn't figure out how to modify, they would sort of eliminate themselves, right? So this is not uncommon. So sometimes I think people think there's something special about, SARS-CoV-2, that they suddenly have variants, but that's not really true. Viruses in general do tend to make variations. The challenge, though, is that the treatments that we're trying to use may be targeted in ways that only affect one particular type of the virus itself, or maybe don't do as good a job on future variants because there has been a change or a shift. And so now what worked in one place doesn't work quite as well. And we're already starting to see that, so that in some of the medications that we're having now, some of the monoclonal antibodies are not working quite as well as they had on earlier cases of disease, as they are on some of the newer variants that we're seeing pop up. And on this slide, you sort of can see where there's been reductions that they've seen, potential inductions, and whether or not we think it'll be important or significant. And particularly the ones in California, it seem like there could be a real significant impact to the fact that these variants are showing up and whether or not they're really going to do well with the neutralizing antibodies that we have available to us. On the next slide, you're actually going to be able to see that there's a distribution of the variants that are occurring. So depending on where you are in the United States, what your concern may be might actually look different than it does to other people. So similar to the way we talk about antibiotic susceptibility for different bacteria, different variants are showing up in different places, which means that certain parts of the country, you might have certain cocktails that may work slightly better or slightly worse, depending on what happens to be circulating around in your town or in your area. There definitely is widespread prevalence of variants, which you can see across the country. And the way that they do this graph, it sort of shows you the regions sort of grouped together. So everywhere you see a gray spot, it's sort of the region that's linked up to the little pie graph that's in that space. And so what you can tell is that there's variants across the country. So there isn't one place that sort of got spared from having variants. But what's interesting to me is that they're not all the same variants. So you'd have to know kind of what's going on in your area to be able to have a true understanding of which medication might be most effective as we go forward, and so that you could pick potentially the right neutralizing antibodies for your particular area.
That's right. And so we have a question right now about we aren't going to know which variants they have been tested for, correct? It's only gives us a positive or negative as far as when you're testing for SARS-CoV-2, and that's true. The testing for variants requires sequencing. Not all labs have that available to them, and it's not a quick process either. And so for example, here in California, we were at Cedars-Sinai the first to discover this California variant. And very quickly, people figured out that it had some issues with the monoclonal antibodies as well as with the convalescent post-vaccine sera. And so the bamlanivimab monotherapy, as Dr. Huhn discussed earlier, became unavailable initially in California, Arizona, Nevada. And the reason why it was restricted to those three states was because that's where we had a higher prevalence of the California variant. What's going on now in the United States is the UK variant is really taking off, really swamping out the other variants. And the UK variant is sensitive to the monoclonal antibody cocktails that we have available, as well as the post-vaccine and convalescent sera. So, public health agencies are following this, and they'll be monitoring it very closely. CDC, FDA, they're all watching this very closely.
Yeah, Peter, I would say, be on the lookout for your public health alerts. You can sign up for those. I get those on a regular basis. And there are laboratories within each state that do surveillance with the PCR sequencing, as you mentioned, to really kind of break down the proportions of circulating variants that would then put a certain threshold or level where we would know that perhaps some of these monoclonal antibody therapies may have reduced activity.
Great. So we're going to now dig a little bit deeper into monoclonal antibodies. And we're really going to start getting into the nitty gritty of how they work and how we treat patients with it. So Greg, could you kick this all off and tell us a little about what a neutralizing antibody or monoclonal antibody is?
the action starts right at the interface of the ACE2 receptor, and that's really on the respiratory epithelium, and that's how the virus engages entry into our cells. And the virus, the coronaviruses, they have spike proteins. They're called coronaviruses because they sort of look like a crown. Here's where some of the immunology comes in. There's 4 different types of binding sites or epitopes. 2 sites called the receptor binding domain, really where the neutralizing antibodies, which is active immunity, which we generate ourselves and also generated through immunization, neutralize the contact point between those spike proteins, receptor binding domains, and the ACE2 receptor. And then the monoclonal antibodies, then that's passive immunity, which are highly specialized neutralizing antibodies to block that interaction, to restrict entry into the human cell's respiratory epithelium. So when we look at the next slide, and we see, well, how do we really make these monoclonal antibodies? We already know about where they have their moment of activity, right there to block out the receptor binding domain spike proteins to the ACE2 receptors. They're derived actually from survivors of COVID-19, SARS-CoV-2. They're isolated from B cells when they're harvested from the survivor's blood. They are then screened for activity against SARS-CoV-2, against those receptor binding domains. They look for what we call the highest affinity, so the highest binding capability. And hundreds of millions of these B cells then, upon screening, we get down to those that are the most efficient to block out that spike protein binding to the ACE2 receptor. They're then grown in bioreactors. So this is very sophisticated, advanced technology, high volume cell culture systems. They're purified, and then they're packaged and ready to go for that passive immune transfer as a monoclonal antibody through now infusion. We see that on the right-hand side. They're now delivered or administered as an infusion. There are more types of delivery systems that are being investigated, but for now, these are infusions. And again, we know when you generate an antibody response, when you generate an immune response, sometimes, again, you're going to have some, I don't even call them side effects. I call them effects because it's an effect of the immune response. Sometimes, again, those flu-like symptoms, perhaps some nausea, diarrhea, these are very well tolerated. That's why there's about an hour or 2 monitoring after the monoclonal antibody is administered. But overall, very well tolerated. It's just actually a sequelae of the activity that is really working, doing its job to block out receptor binding. So Peter, next slide. All right. So Peter, you know, you and I, we were involved in some of those initial BLAZE-1 studies for bamlanivimab as monotherapy, and then we had the combination with the etesevimab. So again, from your position now, you were on the vanguard, very instrumental in moving these trials and agents forward. So can you share some of the highlights here of these trials and importantly, some of your insights?
Of course, Greg. Thank you very much for that. So, you know, here at Cedars-Sinai, we were actually very fortunate. We got involved with the antibody trials very early with the phase 1. But what we have here on the slide is the data from the phase 2 interim study of the BLAZE-1 study. And I want to just reiterate, it was a phase 2 study. This was kind of the interim look, but you have to remember with COVID, everything was a race against time. And so we were trying to get data out there as quick as we could so that people can have a little bit of hope that something might be coming and to have transparency also. And so in this first study where we showed the combination of bamlanivimab and etesevimab, you can see in the bar graph that we had roughly about 100-ish patients. There was 150 in the placebo group, 100 in the treatment group of bamlanivimab and etesevimab together. You know, what we did find in this, the primary endpoint in this first study was viral load and the change in viral load at day 11. And we did find a significant decrease in that. But many of you might be like, well, you know, what's the importance of a viral load? You know, so what we have in this bar graph is a very key clinical secondary endpoint. Now, with clinical trial secondary endpoints, sometimes because of the number of secondary endpoints, the statistics are not as robust, but they're hypothesis generating. And what we found was a very strong signal that got us very excited, because when we looked at the secondary endpoint of hospitalization and ED visits, you can see that in the placebo group, we had about 5.8% of those patients actually ended up in the hospital or having an ED visit, whereas only 0.9% of the patients that got treated ended up having a hospitalization or ED visit. And so very important early study showing a secondary endpoint that had a signal for decrease in hospitalization ED visit. There was also a phase 2 on casirivimab and indevimab that showed a very similar result. But if you go to the next slide, this is when we started really getting some exciting data. And I'm going to give the caveat, these are not published in a peer-reviewed journal yet, but it has been published in other formats. This is the phase 3 study. Phase 3 studies, we have larger numbers. You can see in the bottom of the bar graph on the right, there's about 500 patients in each group, placebo versus the treatment group. We also moved to our primary endpoint as hospitalization and all-cause death at day 29. When you look at the numbers of the patients that were enrolled, you can see that we had very good distribution in our demographics. 29% were Latinx, 9% were African American, about 77% had mild COVID-19, and we really gave it early. They were at about the mean day of giving this was about day 4 into their disease. So very early in the process. One of the other things to remember about this phase 3 trials, we started enriching for those high risk patients, really those patients that meet the EUA criteria, having risk factors, were doing poorly. But you know, what we found here was that we were able to significantly reduce their hospitalization or death. You could see that in the bar graph, 7% of the placebo group had a hospitalization or death. Whereas in the treatment group of bamlanivimab and etesevimab, we had 2.1% that had a hospitalization or death. More importantly, when you look closely at the data, 10 people in the placebo group died, whereas 0 people in the treatment group died. Not one person in the treatment group died in this trial. So we are, and then also some other endpoints, we again replicated that we were able to decrease the viral load. So these data really are starting to show us that these antibodies work. We can keep the patients out of the hospital, probably meaning we're preventing them from getting to the severe disease. And now the data is also showing that we can prevent death. So Margot, there was also a phase 3 data from the casirivimab and indevimab. Do you mind going through some of that?
Sure. So this was actually really exciting for me because, you know, I always like when there's one option, but 2 options is better than even having one. And so what this data showed was that they actually used a similar setup in the trial where the median age of the participants was about 50 years old. They did have 35% of the patients being Hispanic or Latinx and 5% being African American. So there was some diversity. And what they found was that when they gave the medication early, so median duration of symptoms only about 3 days, so slightly less than the other trial, but just a little bit less, they actually found an incredible reduction in death, all-cause death, or rates of hospitalization. So a 2.2% absolute reduction and a 71% relative risk reduction for hospitalization and all-cause death. And I mean, for me, this was pretty exciting just to think about the idea that there wasn't just one potential treatment that was going to work out, but actually now 2 options. Which in a time, you know, when we were having such shortages of being able to get access to medication, having more opportunities to me was really exciting as an option.
Great. And before we move on from that, I'm going to just take a little break and answer some of the questions that are coming to us right now. I'm going to save some of them for later because we're going to cover them. So one of it is, can you provide any variant-specific guideline as to which of the 2 authorized monoclonal antibody combos to use? For the original virus, is one combo recommended over the other? What data supports the prioritization? And really, there is no difference between the 2 combos right now. As we discussed earlier, the public health agencies are following all this very closely. If that changes for your region, they will come out and tell you specifically if you should use one versus the other. At our institution, we don't make a difference. We basically only let you order the monoclonal antibody and we decide based off availability what you get. Margot's nodding in agreement, and I'm guessing many organizations are like that. Okay. And then one other question that came up is the dose is different than what is available. Is the available dose as effective? Some of the data that we didn't show was basically they used lower doses of the antibody, found similar effect. And therefore the FDA, which reviews these data, independent of what the drug company states on a website or whatever. They review the raw data and they found that that is true, that these lower antibody doses have similar efficacy, so they approve these lower doses. And there's a huge advantage of that, because then you have a lot more doses available. You can give it to a lot more people. And someone asked, are these available worldwide? As far as I know, they are available worldwide. Okay. Someone's asking, why are we not discussing hydroxychloroquine? Greg, as an ID physician, would you like to cover that one?
All right, so hydroxychloroquine, as we know, that was the first one that actually was granted EUA as far as a therapeutic, even before remdesivir. And it was really based upon very slim data. We really don't have, as we've seen here, as we've illustrated, these large phase 3 studies. There really was no large phase 3 study at the time when it was granted EUA to show that it was effective. And then when we actually were getting more data, and a lot of this was observational data, not within clinical trials, it just showed that it was not effective. And so we really have no efficacy or data to show that hydroxychloroquine will work in a clinical setting to the degree that the EUA agents that we've seen here actually compose. And so that EUA was rescinded.
And then just to be clear, just so that everybody's on the same page, remember that we were speaking specifically about monoclonal antibody treatments, and that's not a monoclonal antibody treatment. So just remember that we had lots of different treatment options that were going on at the same time, but they're not all working exactly the same way. And so what we were really focusing in on today is the monoclonal antibodies. So neither remdesivir nor the hydroxychloroquine are monoclonal antibody treatments. And so just be mindful about, especially with patients, like helping them understand the difference between the different medications. Because truthfully, it got a little confusing there for a second, because there were lots of medicine names coming out. They're working in different ways.
Right. And as kind of Greg alluded to earlier when he was talking about the NIH guidelines, it's kind of a living guideline. Things are coming and going as we get more data. And I think the data has been very clear that hydroxychloroquine does not work in these patients. Okay, so we have lots of questions now. I'm going to answer one more before we move on, and it really talks about the nuts and bolts. And so I'm going to kind of ask this to you, Greg, because you kind of talked about the mechanism of how the monoclonal antibody works. So after infection, does replicated virus spread from cell to cell with its spike protein already activated, or is it released from a dying cell bearing an inactive spike protein that must be activated before it can enter a healthy cell, suggesting that these monoclonal combinations can reduce cell-to-cell transmission?
Yeah, boy, that's a loaded question. Yeah. And we know that there's cell-to-cell transmission in the bacterial world as well. It's interesting. We showed is azithromycin, going to be effective, and azithromycin, again, for me as an infectious disease doc, that's a kind of a one-time dose, and perhaps when we have a bacterial infection, that we have cell-to-cell infection, and you only give a one-time dose, you don't have enough further down the line, days down the line, that's going to be an effective antimicrobial. And so here, what happens is that if there's a dying virus that's then egressed from the respiratory epithelium, there's going to be viral debris, and so it could actually still be picked up on PCR, but that's no longer going to be infectious. So really, what we know is that the virologic decay kinetics happen within those first 10 days. In mild to moderate illness, it may be 20 days in hospitalized patients. That was data that came out first in the Netherlands, and we've had some observations here. So it's really the former type of mechanism that you mentioned that is really the first actual viral invasion into respiratory epithelium, which is what we're targeting with the monoclonal antibody therapy.
All right, great. I think we're warming up because we're getting a lot of questions, but I want to move on with the rest of our presentation because we might actually answer many of them as we're going. So, the FDA basically gave EUA, emergency use authorization, for these monoclonal antibodies. But within the EUA, they have very specific criteria of who is allowed to get these monoclonal antibodies. So, Margot, do you mind going through that with us?
So Greg already mentioned earlier that there are some people who shouldn't get monoclonal antibodies. So, if you flip back a few slides, you'll remember that people who are hospitalized, people who are having oxygen demands or increasing oxygen demands over their baseline really shouldn't get antibodies. This slide is really focusing in on the people who you should be considering it for. So for adults, you're thinking about folks who have a BMI that's 35 or higher, chronic kidney disease, diabetes. If they've got immunosuppression, either from the condition that they have or from medication that you're giving them that's immunosuppressing them, you should consider them. For folks who are over age 65, or if they're over age 55, but they have heart disease or hypertension, cardiovascular disease, COPD, or another chronic respiratory disease. But keep in mind, if they fall in one of these categories, but they're also having, for example, a worsening oxygen requirement, that may throw them out of the running. But if they're sort of able to be managed on the outpatient stably and that mild to moderate disease, they would be considered a good candidate for monoclonal antibodies. For the younger age groups, so those that are age 12 to 17-year-olds, you're looking at their BMI percentile. So it's an 85 percentile for their age. I'm using that CDC growth chart. So remember, we don't quite measure children the same way we do adults with their BMI. You were thinking about sickle cell disease. You're thinking about any kind of congenital or acquired heart disease in the child already. If they've got neurodevelopmental disorders, or if they've got some other type of sort of technological dependence. So think about things like a tracheostomy, a gastrostomy tube. They have some other kind of issue that they have going on. They might be a good candidate. And then if they have asthma or reactive airway disease, or they've got a chronic respiratory disease where they have to take something every day in order to keep it under control, that's someone that you would want to consider. So for the younger people, you're thinking about things that look slightly different than the adults. But for both of them, really what you want to have in the back of your mind are people who have serious underlying disease that probably are going to get a good benefit from being on the monoclonal antibodies as a treatment.
That's great. So again, remember, use it early. Can't use it in hospitalized patients unless they're hospitalized for some other reason. And if they're on O2, we cannot use them. But what these guidelines essentially, if you have a patient that's infected, you really should start thinking about these guidelines and just think, if they have a risk factor, they probably qualify. And we should really think about giving to all the patients. One group, there's a couple questions about immunosuppressed patients, immunocompromised patients, transplant patients. These are actually very good patients to give it to. Even if they've been vaccinated, we know that those are the patients that tend to not generate a very good immune response, and they can still get active infection after vaccination. And so, there is no contraindication to giving these. Sometimes the monoclonal antibodies, what we have to warn patients about is that they can get an infusion reaction. From my experience, we actually haven't seen any infusion reactions. It's very rare. And it's very well tolerated. And all the studies that have come out have shown that these monoclonal antibodies are safe.
I think one thing to just remind everybody that, like, for me, one of the things that I thought was a stumbling block for me, just as a primary care person, is you have to remember to test the patient, so that if you sort of let the patient sort of ride with their symptoms for a while and you don't get your testing done, so that you don't know that they actually have SARS-CoV-2 until 10 days later, you've missed the window where you could treat them. So have your index of suspicion relatively high and still continue to get people tested. And I think that's really important, because if you miss that part, you sort of delay all the rest of the opportunity for them to get treated.
Okay, so why don't we move on to our very last section before we really start diving into the rest of the questions. We do have quite a few coming through, and we will try to get through all of them if possible. So in this last section, we're going to talk about strategies that you can implement for patients to link them to infusion services for the monoclonal antibody therapy. Because a lot of the questions about how do we get access, how do we get it to the patients? And so to start off this last section, we're going to do another clinical case, but we're going to flip it around. We're going to come from the physician's perspective. And Greg, if you could start us off, this is Dr. Jameson, who took care of our first patient, Stephen.
Yeah, thank you, Peter. Yeah, let's turn the lens on ourselves here. So as we recall, Stephen, 34-year-old gentleman, tested positive for COVID-19. He had a few days of symptoms. He was categorized as mild. But remember, diabetic with obesity, certainly at risk. I would say high risk. I mean, most of we had so many patients, certainly with obesity, we learned that more severe disease. So you've determined rightfully that he's a candidate for monoclonal antibody therapy. But how are we going to navigate? How are we going to recognize and deploy now getting him for access to treatment? So Dr. Jameson calls 3 trusted colleagues in the community. None actually have used either of the combination therapies yet, but they tell her that, that they are also unsure of where to begin. So let's take a look at how we would then move on from here. So based on your experience, how would you advise Dr. Jameson? So contact your local pharmacist to better understand your options. And again, There could be certainly a combination of correct answers here. Contact the nearest hospital system to see what they offer. Contact a subspecialty colleague to see if they are aware of infusion services in the area. If trusted colleagues have had a similar experience, it may be too early to adopt the treatment. My experience is similar to Dr. Jamison's, so I'm not sure what to advise. So let's take a look. All right. So, we all recognize that the trials were done in hospitals, that the hospitals have infusion centers. So the nearest hospital system, see what they have offer. That's certainly a reasonable, and what we see here is, the most popular choice here. Subspecialty colleague to see what they're aware of. Again, gastroenterology, rheumatology, oncology, they all do infusion. So that would be also another place to sort of put your scope on. Local pharmacists to better understand your options. That's only got 3%, but from my standpoint, clinical pharmacists are an invaluable source. They're the caretakers really of the monoclonals, right? Within storage and tracking. So that also might be an option. And then, look, 13% experience similar to Dr. Jamison's. That's why we're here. That's why we're here to take a look to where should we turn to, and Dr. Savoy is going to help us out with that.
Right, and so there are lots of options, but it also requires planning. If you don't plan ahead of time with the anticipation that you're going to need someone to get this, then you're not going to be able to do it within the time when they're infected. So, Margot, do you mind talking a little bit about the barriers that might be to the use of monoclonal antibodies?
There are a number of challenges that we could have sort of just thinking about using the monoclonal antibodies. First, just our confidence in knowing what they are. So if you're like me, you can't even say them half the time accurately. So just not even feeling comfortable being able to get them out of your mouth makes it just a bit of a challenge. And so if you're having that confidence and lack of sort of knowing when or how or what, we're hoping that, talks like this one today will help people get past that. A lack of information. So I found a lot of colleagues just didn't even realize that those were treatments that could be used, or that they were actually safe to use, or that we actually had good guidance about who ought to get it and who shouldn't get it. And so there's a lack of information. Once you get people to actually feel confident about it, to know they need to use it, they need to have access to the infusion centers. And for some people, they may not be located in a city or in an area where there's access to infusion centers, or to people who could give the infusion, even if they didn't have a designated infusion center itself. For some folks, you actually have the benefit of having an electronic medical record that can be robust and actually signal for you that a person's got a certain constellation of symptoms or a certain number of risk factors and might benefit from having a referral to an infusion center. But maybe not everyone has that as an option. And so they're actually needing to sort of figure out that math in their head. And that by itself can be challenging. For health systems, it's been a lot of challenges trying to just get everything all set up, that they maybe haven't done the best they could do at sort of advertising and letting people know. And in the beginning, when the supplies were fairly limited, they were sort of trying to take care of the people they had in front of them. And so maybe they didn't always have the opportunity to let everyone know all the things that they had available, or have the best answer about how you would contact them or get a patient put on the schedule. And so just having a community access point sometimes has been a challenge or a barrier for folks. And then finally, just being able to prepare and administer them. So having people who were comfortable to actually deliver the medication and properly and know that you could have it stored safely was a challenge. And so all of these things sort of combined together to make it a little bit difficult. Fortunately, we're finding that there's people working on all of these areas. And so we're getting much, much better and having better access for folks across the country.
That's right. So, if someone out there is interested in starting up their own infusion center right now, to deliver the monoclonal antibodies because they just aren't close to any current centers. There are certain staffing, recommendations that we need to follow. Margot, do you mind going through some of these barriers that might be challenges in starting it up from a staffing perspective?
So some of the things may seem really straightforward. So, obviously you're going to need somebody who's going to be administrative and able to sort of schedule them and make sure that the person can come in, and that you have access to the medication, and it's physically available in your site. So you're going to need somebody with basic administrative skills that's able to order and access the things that you need to have, and then make sure that the patients are scheduled. But you're also going to need to make sure that you have someone who can genuinely actually give and prepare first, but then actually give the infusion itself. So for some places that might be a nurse. In other places, it could be a pharmacy tech or a pharmacist who's helping to prepare that. And then you have a nurse that's actually doing the infusion and able to take care of that for you. A lot of times they'll talk about needing a healthcare provider or a clinician. It doesn't always mean it needs to be a physician. So there may be a wide range of people in your area who could actually deliver the IV infusion without necessarily needing to have the physician be there the whole time. And so some people think that one of their staffing sort of rate limiting steps is that they need the physician to be the one actually administering it. And that's not necessarily true. You may be able to use your registered nurses. Sometimes your physician extender positions, for example, physician assistants or nurse practitioners may be able to do some of this work for you as well. What you do need to make sure that you have available, though, and this may be a sticking point for some people in office practice settings, is you need someone who's available who can actually do advanced life support and basic life support, so that if you were to have someone to have a serious infusion reaction, you don't want to wait until after they have the reaction to realize that no one is up to date on their ACLS. You want to make sure you've got somebody in the practice who's going to be able to take care of that patient until you can get the EMS services there to get them transferred to a hospital or health system.
Great. So, it's not impossible to start up your own infusion service, but there are challenges. You can see the website currently on the screen right now, and you can come back to the slide later on. You can save the slide now, take a screenshot. But there are, services out there you can go to, and they will help you set your infusion centers up, particularly through dialysis centers, long-term care facilities, and so forth. Okay. So there are a lot of other opportunities to get patients the monoclonal antibodies. If you don't have access to a local infusion service, or you just think it's a little bit too much to set it up yourself, Greg, could you talk about some other things that we might consider?
Sure. So here at Cook County Health, we've actually partnered with local FQHCs to make them aware of our services, to have a referral system, and very much streamlined where they can get into our infusion center. We actually have infusion centers in 2 of our hospitals, and it's really a symbiotic relationship that has been important for our mission to make sure that those in the community are certainly aware of the monoclonal antibody experience here. Urgent care facilities, we did this early on actually within the Blaze 1 trials. They were screening thousands of patients a day, basically. And so that was a referral source. And now there's actually a network that among some of these urgent care settings that infusion centers have been established within the proximity of those urgent care facilities. And that's actually happening throughout the country. And then now with CVS Specialty Infusion Services, there's a potential for home-based ambulatory clinic settings. There's a reference right here through CVS Health. And so really that's one I mentioned on the clinical pharmacy side, very valuable resource to uncover these sites that could be offering the monoclonal antibody administration. And then finally, this, again, further online resources, Combat COVID. This is through Health and Human Services. So this is a government resource where they have national maps, locate these potential treatment sites, therapeutic sites for monoclonal antibodies, also lots of information sheets. And then there's a call center here that will direct you to the right place for the right patient in a timely way. To get your patients the therapy that they need. Great.
So, I'll just reiterate, there's a lot of options out there. There's the website you can go to find local infusion centers. If, you can always look at your local emergency department and see if you can set up an infusion in that emergency department. They have the entire setup you need, but you need to have the drug available. The drug is not going to show up overnight, so you have to think ahead of time. So Margot, can you talk about these drugs and the cost of getting these drugs?
Sure. So I think the most important take-home point is that medications are actually covered. So I think you mentioned it earlier, Peter, that the government is paying for it. So you've actually already paid for the medicines to be available to us, at least at the moment. Who knows what'll happen in the future, but at the moment right now, like you can actually get them through covered sources. So you're not going to worry about necessarily getting reimbursed for them. And it is true that you also have the opportunity to get reimbursed for the cost of being able to deliver the services as well. So I think that, really healthcare professionals shouldn't be stressed about whether they're going to order it, not be able to have it used, or not be able to actually access it. The bigger problem we found is sometimes the access and knowing how to order it, or for whom to order it. This is where, again, from a primary care perspective, our specialty colleagues have been really helpful, so that many of them have systems set up already where they've been doing this ahead of time. And often they can help assist you without you necessarily having to figure out the whole process all on your own to figure out how to get it. But do know that it is covered. And so it's not that you're going to be trying to figure out how to do something for free that you're not going to be able to get reimbursed for on the other side.
Great. So, Margot, Greg, those are just excellent discussions through these three different learning objectives. I think before we head into the questions that we've had, and if anyone has more questions, feel free to put them in the chat box, and we'll get to as many as we can. I'd like to summarize some of the things that we've discussed today with the SMART goals, which stands for specific, measurable, attainable, relevant, and timely. The first one is recognize factors that put patients at risk for progression to more severe disease early to initiate treatment with the monoclonal antibodies. I cannot state this strong enough that you need to identify them early. The earlier you can give them the antibody, the better it's going to have an effect. We could really prevent them from getting to the hospital and preventing them from dying from their disease. The second one is patients who meet EUA criteria should be treated with monoclonal antibodies. That kind of ties into the first one. If they have risk factors, they probably will meet the EUA criteria. You should always be thinking about that when you have a patient that's diagnosed with COVID early on, and be thinking about getting them the treatment, because this is the only therapy we have available right now for outpatients. Third one is proactively identify and establish relationships with infusion centers in your community to refer patients with mild to moderate COVID-19 for treatment. We've gone through potential ways you can get infusions. There's a website where you can go to that will tell you all the local places you can go to get infusion. You can try to set it up yourself. There's websites you can go to help you set those up. You can establish it in your emergency department, in a dialysis center, and you can do home infusion services, as well as there's certain pharmacies such as CVS Quorum, which has set up home infusion services for the monoclonal antibody. But again, you have to have it all set up ahead of time, at least have the drug available so that you can get it infused in their patients, because if you want to give it to them when they're diagnosed, you can't just go ahead and call someone and get that drug immediately. Alrighty, so we've received a number of questions. You can keep submitting it through the Q&A widget. You can email it to us at questions@cmeoutfitters.com, or you could tweet it to @cmeoutfitters. So why don't we start kind of jumping into some of these questions? And I'm going to kind of go with some of the ones that have been sitting around the longest, but I think we might have touched on some of them already. So one is, can you talk about the use of pharmacists for administering monoclonal antibodies? And we kind of touched on that already. Greg, I think you kind of touched upon it. Can you just reiterate those points?
So the pharmacists are the gatekeepers, really, for the monoclonal antibodies. They're the ones actually that are receiving it from the national stockpile. They're the ones that are tracking it. Our pharmacists actually set up our order system. So as an order set, very important that the pharmacists have a role to play there. And then the pharmacists are the ones that are delivering the medications to the infusion centers. So overall, and pharmacists are the ones that are making sure, they're the ones that are double checking whether all the check boxes have been clicked to make sure that everything's set up to have a seamless experience with the administration of the monoclonal antibody. So I believe, I'm a big fan of clinical pharmacists, that they're just invaluable within our overall flow. So I think the clinical pharmacists are the ones that really have their pulse on both the supply as well as the overall operations for the infusion centers.
Great. And Margot, I'm going to ask this question to you. How do you address patients' fears regarding monoclonal antibodies?
So for me, I like to start with what it is they're actually concerned about. So a lot of times what I'm finding is that, with a lot of the treatments, but also with COVID just in and of itself, people just have a lot of concerns because they feel like everything is new. And they don't necessarily understand how we know that the treatments that we're giving weren't just made up yesterday and going to hurt them. And so for me, a lot of times I just want to start with hearing them out first and understanding what it is they're actually concerned about, and then addressing the specific thing that they're worried about, so that, in the places where we don't have the right answers, so that we can't tell them exact things, being transparent and honest about that. But in the other places, being able to reassure them about things that we know for a fact. So for example, many of these medications that we're talking about didn't just exist from yesterday, right? So that we've been using them for other treatments so that we know that they're safe. We just don't always know if they're effective until we have the opportunity to use them in the particular diseases that we're talking about now. And so the things that people tend to be worried about, is it going to kill me? Is it going to hurt me? Will it make me worse than I was before? We can sometimes answer those questions just based on the safety data that we know from how it's worked in other diseases that we've used them for, or in similar medicines and how they've worked for folks. And I found that to be really reassuring for a lot of patients, and just helping them understand why we're trying this in this particular case and what data we do have available, and then letting them know that we are really truly doing a great job, better than almost anything I've seen us do, in my lifetime, tracking how things are going. So actually being really good at knowing when people are having reactions we didn't expect, and when people are having side effects that you didn't know were going to happen, and being able to get that information back to clinicians so that we can make better choices as we go forward. And I think that's really important to help patients understand, so they don't have to be so afraid about whether or not we're just making it up on the fly. Because the truth is, for some of the things we did have to make it up on the fly, but it was based on a really strong foundation. It wasn't just random things that people were picking. They were making very educated choices, which is why we found things that actually work. And I think that helps people when you really can explain it to them that way.
Yes, I totally agree. And, I think you have to remember that the trials were done with rigor, and all the trials show that there was no significant side effects with the treatment versus placebo. We have a lot of real world data now. We've given these monoclonal antibodies probably to hundreds of thousands of people now across the United States. And any adverse reaction has to be recorded, and you haven't really heard of any bad reactions happening, and if it did, the news would be all over it. And so, the risk of you having an adverse reaction from the monoclonal antibodies is very, very low, but your risk of dying from COVID is probably pretty high if you have these risk factors. And so, the cost benefit ratio is enormous when we think about this.
Yeah, same discussion we have about vaccines, right? So,
Exactly.
So I mean, vaccines, again, active immunization, monoclonal antibodies, passive immunization. It's a instant immune response. So it's really very similar. And we know the safety with vaccines. We know the safety with monoclonal antibodies.
Yeah, I mean, if you had a patient come in and they had cancer and you wanted to give them a biologic, no one would hesitate, right, in giving that biologic. And so we've had a lot of experience with biologics. The one interesting thing about these monoclonal antibodies is, if you think about how it was created, it's quite amazing. Greg already discussed the mechanism and how they identified it, but we plucked this out of a human body. And as we all remember back to medical school, we have positive and negative selection. So your immune system has created this antibody that we know will bind the virus, but won't bind yourself. And all the companies have done these cross checks to make sure that they don't have any binding to your human body. So there's no autoantigens here. It is very specific to the virus. And so these biologics work. They're specific. They'll go away over time. They have a very long half-life, probably about on order of 3 weeks. And so they'll sit around in your system for quite a while. But this is passive immunity. It does not substitute vaccinations, which basically is the gift that keeps on giving, because your body is making those antibodies for a long time. All right. So then the next question I have on my list is, if we don't see changes in status, can we increase the dose? This is a single dose infusion. There is no change in the dose. You give one dose to the patient. They are covered for a very, very long time. Half-life is roughly about 3 weeks, as we just discussed. And so, you're looking at several months before it's at a very low level in their body. And so this is just to kind of cover them, as their own immunity builds up towards that virus long term. Okay. Any data to support?
That's a good place to point out, Peter, before you move on. That's a really good place to point out the fact that, if you were to give a dose and you really thought the person wasn't getting better, you don't just say, oh, well, I guess that didn't work, and leave them be. You would go on to treat them with other things. And so, some people might go on to need to have, additional care, escalated care. And so if you really gave it and you thought you needed to give another dose, that'd be the part where you need to be thinking about whether they need to be in the hospital and whether they need other additional therapies.
Right, exactly. And, the second question I have on my list that was kind of a corollary to that is, any data to support switching from one to the other if limited to no efficacy in the first tried monoclonal antibody? No, it's a single dose. These antibodies sit around for a long time. by the time, honestly, most if you do have people that don't respond, they're going to be out of the window anyway for dosing. So it's a single dose. You don't switch to another one. Can donors who are post-infection of COVID-19 and vaccinated and a history of donated blood for use in monoclonal antibodies? Sorry, I'm having a hard time understanding. Can donors who are post-infection of COVID-19 and vaccine and a history donate blood for use in monoclonal antibodies? So these monoclonal antibodies are not donated. This is not convalescent plasma. What the drug companies have done is they identified someone that resolved in their convalescent phase, plucked out the B cells that actually bind the right site, and now they have the B cell, and they put them in these bioreactors, as Greg discussed, to basically create big buckets of these antibodies that they can purify. Okay. Are both combinations equally effective against different variants? Margot, I'm going to let you discuss that one because you kind of touched on the variants.
If you scroll back up to the slide later, so you don't need to do it now, and you look, they sort of go through one by one and show you the sort of different reductions based on different neutralizing antibodies. They do know that certain ones of the variants seem to have different reactions to different different parts of the neutralizing antibodies, so that we know that there may be certain ones where you may have a reduction in one place versus another. I don't know that they necessarily can tell you that if you were to be in New York, you can never use this antibody versus that antibody. I do know that, for example, if they know that in the circulating, in what they're seeing circulating in the underlying testing. So for example, in Pennsylvania, if they see that there's a certain thing circulating, it seems that our infusion centers are using one med versus another med based on what they see circulating in general. But as the primary care person, I'm rarely telling them what I want them to order at all. I'm just saying this patient seems to be appropriate, so I'm sending them to you, and then they're making the decision based on what's circulating in the area. And so that's the way I would think about it. So I'm not sure that we would ever have enough data to be able to hand select, as individual primary care people, what you would want to give based on what's going on. But I do think that they're working on moving towards figuring out exactly which variants, how you would know which variant this particular person has, and then be able to match it up later. I just don't know that we're all the way there yet for both the testing side, but then also matching up with the medication and the supply side.
I'll also mention that, this is not a static type of situation right now. There's monoclonal antibodies that are in development right now. Speed is a factor, right? Speed's a factor for vaccine to limit the transmission, dissemination of these variants. Speed also in developing newer monoclonal antibodies is going to be important. So you're going to see actually a wider breadth of monoclonal antibodies that will come on the scene as we uncover more of these variant mutants.
Right, and a question I see right now is, do monoclonal antibodies work against all variants? The answer is no. There are variants that are resistant. We see this on this table right now. But the public health agencies, as we discussed, they're monitoring this, and they will basically tell us if there are certain regions that we need to be changing the way we approach our therapies. So Greg, I'm gonna ask you this next question. Can you combine remdesivir and monoclonal antibodies?
So you can't combine them, no. Again, remdesivir is inpatient and monoclonal antibodies are outpatient. So if somebody progresses after their infusion of monoclonal antibodies, if they are admitted to the hospital, that patient, by our protocols, usually will get remdesivir. So if it's a matter of, are you restricted that you can't use remdesivir after a monoclonal antibody, the answer is no, but you're not going to give them together.
Great. So the next question is, will the immune response triggered by neutralizing monoclonal antibodies protect against future COVID-19 infections? And we kind of touched on this a little bit. Greg discussed it. This is passive immunity. This is not active immunity. And so passive immunity means we are giving them the antibody. It's protecting them while the antibody is around, but those antibodies will break down over time. Active immunity is if you've been vaccinated, if you've been infected, your immune system has the B cells there, the memory B cells, the plasma cells. They will keep squirting out these neutralizing antibodies to protect yourself long term. All right, so there's a couple questions about dialysis centers, dialysis patients. I'm going to ask you, Margot, if that's okay. So what about alternative sites such as dialysis centers or home? And then also, I assume dialysis patients should get these monoclonal antibodies.
So I know in our area, you actually can get your infusion at the dialysis center because they found that it actually made sense. We had a high rate of people getting infected because they were still having to go get their dialysis, and people were having, they were just having a lot of close contact because of the way dialysis is set up in general. And so they were actually able to give the treatment at the dialysis center without you having to go to a second site. So they would do your dialysis and then do the infusion after. I don't know if that's possible everywhere, but I would imagine that that's the type of thing that I might ask in your local community ahead of time where people have access to centers. I mean, I happen to be in Philadelphia and there's a lot of resources. So we tend to be a resource rich city. So there's lots of opportunities where people could get access to that. I can imagine that if you might be in a more rural setting or a place that has less access, that you might find that there are already people who have thought this through, particularly through your public health department. And even if your dialysis center wouldn't normally do an infusion, or for example, we found some hematology offices who were already doing iron infusions and things like that. So they already had this set up. We're actually sort of doing some of that work out of their practices, even though it's not what they would normally do because of what was going on sort of in the pandemic. They were willing to take that on in certain communities. And so you might need to find out in your local area, sort of who's doing that or who's available to do that in your area. But I certainly know that in our space, we've been able to do that in partnership with some of the dialysis centers without too much trouble.
That's right. So, in one of the websites that we had given earlier, where they help you set up infusion centers, there's a link in there. And basically, one of the sites they focus on are dialysis centers. Exactly. The slide is up right now. If you go to that site, you have a dialysis center, they will actually help you set up infusions for these monoclonal antibodies in dialysis centers because they're a perfect place for it. I previously have talked to a CMO of one of the larger dialysis groups across the United States, and she discussed with me getting it in their dialysis centers. She set it up. She emailed me, said that they've had great results, and from their internal data, seen that they've had a lot of success in reducing hospitalization and death in their patients. So absolutely, dialysis centers are there. I think other things we've talked about, kind of skipping ahead through some of the questions I see coming down the pike, infusion services. You can find home infusion services in your area to give it, use it, but you have to have that drug available. You have to store that drug somewhere. So go to the websites that we've provided, order those drugs. They're free, completely free. We've all paid for it already. And so get those available for your patients and having home infusion services worked out to give it to them. If you're in a big city where CVS Quorum is actually giving it, that you can just call them directly with an order and they'll go to the home and infuse it to your patients. Okay. And then a final thing, emergency departments. You can give it there too if you need to. All right. Some other questions here I'm going to quickly answer myself. Would you treat a child younger than 12 if a family member was at risk? No, you can't. It's not within the EUA. You cannot give it to anyone that's under 12. The next question is, we shouldn't give it if on oxygen, but is it okay if they trached? If a patient is on oxygen stable level, doesn't change, I believe, Greg, you can correct me wrong, that's actually okay within the EUA. If they're trached, stable level of air or whatever oxygen they were on, as long as that hasn't changed, it's okay.
Yeah, that's correct. Yeah, I mean, if that's their basal sort of oxygen requirement, and they're not progressing due to COVID-19, then certainly that can be administered then.
All right, so then the next question is, what about an oral form of the monoclonal antibodies to eliminate the barrier of infusion therapy? You honestly can't take oral monoclonal antibodies. Your stomach will break that down. It's a protein, and the stomach acid will break it down. There's a lot of studies ongoing about different delivery methods. I know sub-Q is one of them. And so hopefully they're going to continue working on that to make this an easier method to give patients, because the infusion service is quite a barrier right now for many people. Okay, I'm going to ask this next one to you, Greg. Do the monoclonal antibodies suppress the body's ability to form its own antibody response from the viral exposure of vaccine number 1? Yeah,
that's a great question. And I was going to jump in at several points to sort of try to clarify that. No, actually, the monoclonal antibody, and we're discovering this, the monoclonal antibodies do not appear to impede the body's own ability to generate an immune response, both with infection or by vaccination. So the question is reassuringly that monoclonal antibodies do not sort of run interference within that host immune process.
Right. The CDC offered the guideline of saying wait 90 days to be vaccinated afterwards. If you've been given the monoclonal antibody, they don't have data to support any of that. It was just kind of an abundance of caution because the monoclonal antibodies do sit around for an amount of time. But what we do know from other studies is that even if you're given the monoclonal antibody, you still will mount an immunity, suggesting that the monoclonal antibodies do not interfere with that process. Okay, question is, were monoclonal antibodies tested in African American and Latinx populations to communities that were disproportionately affected by COVID? Absolutely. There was a wide distribution of these, and they were well represented in all the trials. And so we know this works across all of them. And we know those communities actually have been suffering very bad outcomes from this disease. And those are ones that you really need to be thinking about when it comes to this. All right, I don't know if we're gonna get through all these questions. We have a lot of questions. I'm gonna take maybe a couple more. I'm gonna focus in on the ones that might, okay, so does timely administration of one of the monoclonal antibody combos reduce the risk of long haul COVID or the risk of the MIS-C? The answer is we don't know, but probably not. But Greg or Margot, do you have any insights on that?
I would say we really don't know. Certainly, we need to look deeper into the mechanisms of long haul or just long COVID. But right now, as far as monoclonal antibody therapy, no, we just don't have that data.
Okay, let's see. I'm trying to identify, I think we've hit most of, there's a lot of questions about variants still, but I think we've asked that. We've answered the stuff about being given in dialysis centers. I think as we're kind of moving into our last few minutes, Margot and Greg, do you have any last words that you think that we may have not touched upon today?
I mean, my only take home point is still that tell people they need to get vaccinated so that prevention is still better than any treatment that we might have to come up with. And so getting people vaccinated is still critically important. And to have your threshold relatively low for getting the test, that if you're not sure whether this person has allergies or a cold, or if they're truly having COVID or SARS-CoV-2, that, I mean, honestly, get them tested, because not getting them tested delays the entire opportunity to get treated in the first place. And I think that's a real shame. So for me, those are the two things I would take home.
Yeah, I mean, I would certainly echo that, and spread the word. Not only, I mean, we're all advocates, right, for vaccination, but now with this knowledge, knowing, having the awareness of monoclonal antibodies, where to actually access them, how to screen patients, early intervention is very important. Spread the word to your colleagues. It's going to be very important.
Absolutely. And, I think this has just been a fantastic program today. I've really enjoyed working with both of you, Greg and Margot. It's been fantastic learning from you and hearing about your experience from this. So you can see on the screen right now, if you want to receive CME or CE credit for today's program, complete the post test on your screen and then click on the Request Credit tab to complete the evaluation and print or download your certificate. Don't forget to collect your COVID-19 monoclonal antibody treatment digital badge. You earned it if you'd like to have that for any of your social media. If any of your colleagues missed today's program, or if you want to refresh yourself, it's archived at the COVID-19 Hub. I encourage you to check out the COVID-19 Hub for all the resources that they have available for not only yourself, but for your patients. So thanks again to both of you, Margot and Greg, for joining me today. It's really been an excellent program. And I also want to thank the CME Outfitters for their assistance in developing today's program, and stay safe. And thank you again for providing the best care for your patients.